তো ম্যাডাম আপনি শুরু করেন, তারপর আমি আমার প্যানেলকে ইন্ট্রোডিউস করব, আমার টিমকে।
Ma'am, we are on live.
Sorry. Okay, thank you, Dr. Rehana, and I think it's Dr. Kobita Sivakumar. Yeah, welcome in Planetary Health Academy. Yes, I think there is Dr. Ali Ifsarara. Ali Farah also is here. So we are grateful and we are very much excited to know about the male infertility. Actually, in our country, it is also a burning issue, and now the male partners they are now just own their problem. Like they are coming forward and they are telling. Actually, in our country, it was all the blame goes to our female partner. The male partners always do that. No, and our in-laws are also they are telling, no, my male partner is always okay. So now they are not coming forward, and we are facing a lot of male infertility patients are coming. And actually, it is I don't know why those who are staying outside in the Middle East also they are coming. They are coming with the male infertility problem with the male infertility partner is coming now. So I think I will not go in details. You will be telling everything, and I will learn so many things from you. We are waiting for this. Now we can start the program now.
Okay, Assalamu alaikum everyone, and good afternoon. I like to introduce myself. I am Dr. Rehana Zaman. I'm the clinical lead, Obs-Gynae lead for this PHA, which is Planetary Health Academia. This is a platform where all the Bangladeshi origin doctors are trying to help out Bangladeshi juniors and others. So we do this teachings quite frequently. So today's topic is male infertility. And I like to invite my colleague, Dr. Ali Al-Farah, to introduce himself. And then Kavita will introduce herself, and then Kavita will start the presentation. Thank you.
Good afternoon, everyone. I'm Ali Al-Farah. I'm a consultant Obs-Gynae at James Paget University Hospital. Been a consultant for the last 13 years, and I'm the infertility lead for the service. After I finished my training in Obs-Gynae, I spent 3 years working at Manchester Infertility Service and also Cardiff Infertility Services before I got my consultant post. I'm very excited to be here today, and thank you very much for inviting me, indeed.
I am Dr. Kavita Shivakumar. I'm a specialty doctor, associate specialist in obstetrics and gynecology, and I have special interest in infertility and early pregnancy. So I work in this hospital, which is a small unit, which is a satellite unit. So we do fertility clinics and see couple and do their basic investigations. And also we do the basic investigations and do the initial treatment here. However, if any patients needs IVF, they are referred to an IVF unit, which is a tertiary level unit in UK. And then we follow the protocols from there, do the basic preparation, and the patients are transferred to a tertiary unit for as such the egg collection and embryo transfer. And then they come back here and we follow them as well. I think it's echoing someone. You might need to go to a different room. I think so. Yeah. Might help. Okay, so I'm here to talk about male infertility. So it's mostly a theory part, but I have done a clinical approach as well. So I'm happy to answer any questions at the end. Infertility is inability to conceive after at least 12 months of regular unprotected sexual intercourse. As such, the incidence is growing and it's 15 to 20%. Male factor is becoming a worldwide epidemic. The exact cause of the decline in male infertility is largely unknown. However, it may be due to various environmental factors as lifestyle changes such as smoking and obesity. Male factor per se may be responsible 30%, which is about 1/3 of the infertility cases, and 20% as a contributing cause. So it's very important when a couple is investigated, they are investigated as couple, both male and female are investigated together. So the first step is semen analysis, which is the gold standard for the fertility evaluation. So when we say semen analysis, the instruction is very, very important. As sperm motility in the ejaculate decreases with the time after ejaculation, it is important to initiate the examination within half an hour of ejaculation. So what we do in our hospitals, we do a pre-printed form to give to the patient with special instructions as well. We explain to them. So the instructions that's listed is they should abstain from ejaculation for at least 2 to 5 days. And the sample should be produced by masturbation, and advise them not to use a condom or a lubricant, and make sure the sample arrives at the lab within an hour of production, and make sure it's not sitting there waiting to be analyzed, and the initiation or like the starting of analysis is done straight away. Of course, put the patient's details in a particular way and avoid to exposure too much heat or cold, as we know that will alter the values. So this is a reference value which we follow, which is a WHO standard. So obviously the data suggests there's been a constant decline in semen parameters throughout the decades of 20th century, but the values are almost staying the same. So the volume should be at least 1.5 ml or more. Sperm concentration, we look at total sperm number, which should be at least 39 million sperm per ejaculate or more. And we look at the motility. So together, progressive and non-progressive motility should be at least 40% or more, or at least 32% of progressive motility. For morphology, at least 4% or more should be normal. So usually when we do a semen analysis, if it comes as abnormal, most of the time we do a repeat one, and we should ask them to repeat at least 3 months, because the whole spermatogenesis process takes place in 70 days. However, if they are grossly abnormal, we no need to wait for the 3 months. We can ask them to repeat it straight away and initiate further investigations. This is a slide which shows the comparison on the semen parameters from the men in couples starting a pregnancy within 1 year of unprotected intercourse leading to a natural conception. This is 2010 and 2021. If you really look, there has been no much difference either on the sperm count or on the motility, which is 32 and 30%. So there has been no major difference in the sperm parameters. So this is a list of external factors that influences on the sperm parameters. Although the causes and impact gametogenesis cannot be readily identified, the extrinsic factors definitely play a role, which includes diet, physical activity, body habitus, environmental factors. These external factors could be modifiable, and maybe it can provide a therapeutic opportunity. So let's look at them individually. So diet. Definitely there is evidence to show, some evidence to show that dietary modification, which includes adding up some supplements in the form of zinc or omega-3, shows there is favorable improvement in semen parameters. So there is evidence to show that. However, with the clinical pregnancy rate, we are not sure. So we will discuss in detail a bit later on about the same. Alcohol, the health and social care limits to 3 to 4 units per day for men, and they say it is unlikely to cause any effect on the semen quality. However, they ask us to avoid binge drinking, and they say excessive alcohol intake is detrimental into sperm quality. Smoking, there's definitely association between smoking and reduced sperm quality, although the impact of this on male fertility as such is uncertain. However, we do tell men that stopping smoking will generally improve their health. So it's better to try and do the same. Caffeine, there is no much evidence on caffeine intake and its influence. It's not consistent. So we don't say much about it. However, we do encourage men to take diet rich in vegetables, fruits, fish, and low fat dietary products, which does help positive improvement with semen quality. And this is from NICE guidelines, and advise them to avoid processed food and meat. Stress, with the new modern world, stress does play a major role. There is a large meta-analysis reports that say psychological stress could lower sperm concentration and motility and increase the fraction of sperm with abnormal morphology. It is thought that effects of sperm are because the stress causes raised steroid levels, and it can cause primarily suppression of testosterone. Obesity, so men over BMI of 30 or over should be informed that they are likely to have reduced fertility. Again, NICE points out that we have to counsel the couple when their BMI is 30 or over and advise them to lose weight. Men also should be informed that there is an association between elevated scrotal temperature and reduced semen quality, but that it is uncertain whether wearing loose fitting will improve or not. Sleep disturbance is getting very common in the modern world, especially with the use of a lot of devices. Again, its prevalence is increasing and it may contribute to infertility. So let's see how obesity can affect. So obesity can itself induce oxidative stress that can cause DNA damage in the sperm. Obesity also can cause increased estrogen, which can have a negative feedback in sperm production. As well, obesity can increase the scrotal temperature, which can affect the sperm motility. So altogether, obesity does play a major role. Oxidative stress can influence the sperm in various levels. It can affect the cell membrane of the sperm. It can cause DNA damage and can affect sperm dysfunction. And thereby, it can affect sperm motility and reduce the ability to fertilize the oocyte. So let's see the commonest causes of male infertility. So the patients could have either azoospermia or can abnormal sperm parameters. So let's start with azoospermia. So azoospermia is basically absence of any sperms in the semen analysis. So obviously we already said that if it's abnormal, if there's absent sperm, then we have to repeat and give 3 months to repeat the sperm. But if it's completely absent, then we no need to wait for that long period to repeat the semen analysis. Let's do a bit of basic here. So a bit of physiology, how the sperm is produced. So the hypothalamus stimulates the GnRH, which stimulates the pituitary. The pituitary releases FSH and LH. FSH stimulates Sertoli cells and LH stimulates Leydig cells. So Sertoli cells is involved in the production of spermatogenesis, which helps in producing sperm with the help of testosterone, which is secreted by Leydig cells. However, there is a hormone called inhibin, which is also secreted by Sertoli cells, which has a negative feedback inhibition in the pituitary. As well, testosterone does do negative feedback in the pituitary as well as hypothalamus. So once the sperm is produced in testis, it's stored in epididymis, and along with the secretions of seminal vesicle, prostate, and bulbourethral glands, the sperm is transported via the vas deferens and it comes out in the ejaculate. So we need to understand the physiology very well so that we know at what levels there could be problem with the sperm production. So the etiology of azoospermia can be divided into 3. So first one is pretesticular, which is a non-obstructive cause of azoospermia. The second one is testicular. So the problems at the testicular level, again, mostly it causes non-obstructive azoospermia, and it could be post-testicular, which is traditionally called as obstructive azoospermia. So the pretesticular could be at the higher levels, which can affect the pituitary and the hypothalamus. If this is a testicular, there could be problems with the testis, where could be deformities in the testis, and then post-testicular could be either obstruction of the reproductive tract or could be an ejaculatory problem. So we'll see each one of these branches in detail in further slides. So to begin with, this is at the higher level where there could be a problem at hypothalamus and pituitary. So this is a pretesticular non-obstructive azoospermia, and we also call this as hypogonadotrophic azoospermia. So the etiology could be genetic or acquired. So the genetic could be Kallman syndrome, which is one of a rare condition which affects about 1 in 20,000 of males. In Kallman syndrome, there is abnormality in GnRH production. So these GnRH production can also affect the olfactory cells. So these men can present also with anosmia. The acquired cause could be a pituitary tumor or pituitary radiation or any head injury. So the history plays a major role in this. And also hyperprolactinemia could be one of the cause, which could affect the higher level, and it can cause hypogonadotrophic hypogonadism. So FSH, LH, if you do the investigation, they are going to be very low. And if it's a hyperprolactinemia condition, obviously the prolactin is going to be high. Again, history is very important. So they could give history of any past head injury or history of surgery in the brain or history of pituitary tumor, history of radiotherapy to the pituitary gland. So these play a major role. So obviously, if you have any of these doubts, one of the investigation we would want to arrange is to check the MRI of the pituitary as well. So let's go to the next level. So this is a problem at the testicular level, where it is a testicular-mediated non-obstructive azoospermia. So this is called as hypergonadotrophic hypogonadism. And also we can say there is a primary testicular failure in these men. Again, the causes could be genetic or acquired. So with the genetic cause, the Klinefelter's is one of the commonest condition, which could cause primary testicular failure. History of trauma or torsion should alert a bell. There could be past history of infection, for example, mumps orchitis or epididymitis, that could have caused some problems with the spermatogenesis there. History of testicular tumors, again, history of irradiation or chemotherapy could have damaged the testicular cells. History of varicocele is, again, that has to be kept at the mind about this. So if you do the investigations, obviously it's FSH and LH is going to be high. So it is called hypergonadotrophic, and the testosterone levels are going to be low. And if you're suspecting the primary testicular failure, you do arrange for a genetic test to rule out Klinefelter's and other ornitholoides. You do arrange for a scrotal ultrasound scan to check if there is any varicocele. So post-testicular causes. So post-testicular causes or called obstructive causes of azoospermia, there is no problems in the pituitary gland releasing the hormones FSH, LH. There is no problems in secretion or production of sperm. However, there could be issues from the sperm carried out from where it is stored all the way through the vas deferens and released. Again, it could be congenital or acquired. So in the congenital part, we have to remember cystic fibrosis as one of the main cause, which is most commonly associated with congenital bilateral absence of vas deferens. Again, that could be a trauma or infection of the reproductive tract that's caused problems in transport, or it could be a simple ejaculatory duct obstruction. Also, the other causes which we have to remember as acquired causes, there could be history of surgery in the past. It could be history of orchidopexy, history of vasectomy, or history of any hernia repairs. All these should alert a bell there. So when we do investigations, the FSH level, LH levels are going to be completely normal. So we do arrange for cystic fibrosis screen to check for CFTR gene, and we arrange for imaging, do a scrotal ultrasound scan to check the testicular size, as well as you arrange for transrectal ultrasound to check about if there is any issues with the vas deferens or prostate. So these are the three levels when we where there could be problems, which we have to keep in mind when we have to do the history and clinical examination. So thorough history in men is very, very important. So you start from the commonest things which you could think of, which could be a history of trauma, history of torsion, history of any infections in the past, history of surgery, history of tumors or history of chemotherapy or radiotherapy, any history of undescended testes, history of varicocele. And also you then ask about if, was there any issues in developmental secondary sexual characters in these men. Smoking and alcohol consumption is very important. You also do history of drug usage and whether any steroid intakes in the past. Assessing their BMI is very important. Also check on the occupation. Obviously, if they're working in a pesticide industry or metal industry, then they can affect the spermatogenesis process. However, then comes the examination, analysis of the testicular size and consistency, and PR to check the prostate. So then you arrange for the investigation. Obviously, there's azoospermia. So the next step is to check the hormones. So checking FSH, LH, testosterone, and prolactin, especially to differentiate between pretesticular, testicular, and post-testicular causes. And also arrange for ultrasound scan of scrotum to determine the testicular volume and presence of any varicocele, etc. Also, you arrange for transrectal ultrasound scan to look for any obstructive causes there. And if any suspicion arises among the above things, then you do arrange for genetic testing, which includes karyotyping, microdeletion analysis, and cystic fibrosis gene testing. Once we do all the investigations, if obviously needed any further input, then what we do here is we do a referral to the combined IVF infertility andrology clinic in UK, which would be a tertiary unit. So let's discuss a couple of cases here. So that will let us understand an approach to a patient presenting with male problems here. So the first one, so KB and EB was seen as a couple together in the infertility clinic in January 2017. KB is a male who's 35 years old. He's a white South African. He's a non-smoker and he's a vegan. He does take pea protein supplements. He drinks about 3 units of alcohol per week. He works as a massage therapist, and the couple together have 7 years history of primary subfertility. KB is a serious bodybuilder. He did have semen analysis in South Africa a few years ago, prior to starting his bodybuilding. He didn't have any details with him. He was not sure about what the count was, but certainly he was told he had low motility at that point. He's been using regular steroid for his muscle enhancement. So when we saw him, we arranged for a semen analysis before he came to our clinic, which showed the count to be 2 million per ml, and it was 0% motility. So we did advise him to stop steroids, and so that we could repeat his semen analysis to see. So eventually, after convincing, he managed to stop his steroids in October 2017. So repeat semen analysis was done in March 2018, which was almost a year after. The volume was about 5 mLs. However, they were still azoospermic. The FSH and LH levels were very low, and the testosterone levels were almost normal. So at that point, we made a differential diagnosis. Could this be a hypogonadotrophic hypogonadism, where there could be a problem because of his steroid, which has made issues higher up? Or is the pea protein supplements that he is taking has some suppressive effect on the gonadotrophin production and thereby sperm production? So at that point, we decided we'll advise him to stop his pea protein and advise to do a semen analysis. And we also did a referral to an IVF fertility andrology clinic for further advice and opinion. So the advice that was given from there was to check his prolactin levels, and if it is normal, and if there's no female factor involved, and there is also the age of the female is not too close to 40, then we could do a trial of see whether you can take HCG 2000 international units twice a week for 3 months and see whether we could do a repeat semen analysis at that point. And if the semen analysis shows some sperm at that point, then we could consider possible ICSI. So he did take the HCG for 3 months. And the repeat semen analysis after that in October 2018 showed the count to be 22 million and the motility was 50%. So the plan was to do sperm freezing, for which the patient had to go to a tertiary unit and had his sperm frozen. Meanwhile, the female was investigated to get her prepared to receive an embryo. However, it was noted that EM had a endometrial polyp in the ultrasound scan, so she did have an hysteroscopy and polypectomy. The couple went through 2 cycles of IVF-ICSI with a single embryo transfer. The embryos were not of great quality. She did manage to get a biochemical pregnancy twice, but it was not successful. So they went for the last and third cycle of IVF-ICSI, and that time it was a double embryo transfer into 2020. Even though they were slowly developing embryos, she did get pregnant, and the child is 2 years old now. So that's case 1. Let's move to the second case. Again, this couple, VB and PB, was seen together in the infertility clinic. The female partner, she was 35 years old, regular periods, ovulating, normal BMI, and there was no significant issues with her. PB was 35 years old. He had fathered 3 children from his previous relationship. He had a history of vasectomy at when he was 27. So they were seen in the clinic in December 2021, and the diagnosis of secondary male fertility was made at that point. They had 2 options between them. So the first one is to see whether we could aspirate any sperm and then go for a IVF-ICSI or go for a reversal of his vasectomy. So the patient preferred the first option because they decided they only want 1 child, and considering the partner is already, female partner is already 35 years, they don't want to wait for a long time. So they were referred to the IVF fertility andrology clinic in UK at that point for their input. So the couple was reviewed in April 2022 in the IVF fertility andrology unit, and the plan was to go for a PSA, which is a percutaneous epidermal sperm aspiration. He did have this procedure in May 2022, which was done under local, but they could only retrieve immotile sperm. So at that point, he was seen by a urologist, and he was planned for a MESA, which he had successfully went through in the GA, and they managed to retrieve sperms and they were stored. So the couple went through an IVF-ICSI in November 2022, and they were good because they were good quality embryos. They had a blastocyst single embryo transfer, and she's pregnant now, 20 weeks pregnant now. So the approach is always based on the serum FSH. So once you get to know the azoospermia, then you do the FSH, and then you categorize them into hypo or normo or hypergonadotrophic hypogonadism, and then you follow each pathway how you handle them. So just repeating this, if FSH levels are low, they are hypogonadotrophic. So the problem could be in the higher level, but it could be pituitary or the hypothalamus. So you do the other investigations, which includes a prolactin level, an MRI and CT, and there. This is a group who benefit from gonadotropin treatment, and then we could see whether they would grow any sperms and take that route. So the next one is hypergonadotrophic. So if FSH levels are high, then the primary testicular failure is what we should be thinking. And the first investigation that we would want to think in their stage is genetic testing to test for aneuploidy. So there are 3 types of aneuploidy which we could be thinking, but the commonest one is Klinefelter syndrome, which is most common, and about 11% of azoospermia males are affected. But there could be other causes, could be translocation or Y microdeletion, but many of the times it is very difficult to determine the exact cause, what was the issue in these men. So the genetic testing not only helps us to know whether they could benefit from surgical sperm retrieval to see, but also helps us to identify about the particular genetic condition that could be passed on to the offspring. So when you arrange for genetic testing in male infertility, the commonest thing we look for is karyotyping and CFTR gene mutation. The less common ones are Y chromosome microdeletion analysis. So few words about Klinefelter's here. Klinefelter's is commonest form of chromosomal aneuploidy in infertile men. It's one of the commonest form of hypergonadism. So these men will have an extra X chromosome, so they're called 47XXY. So they do have small firm testes. They do lack secondary sexual characters as well. So more than 90% of affected men are azoospermic. So these men, testosterone can be given only to improve bone density or prevent osteoporosis and improve their mood and libido. But there is no role for any, there is no role it says that it improves any fertility issues in these men. The other less common, which we think about, is Y microdeletion. About 2 to 10% of men are affected with azoospermia have this issue. 10%, it can be 10% cause of non-obstructed azoospermia and 5% of severe oligospermia. In case of primary testicular failure, obviously the option would be to consider surgical sperm recovery after treatment of gonadotrophins. And if we could find any sperm, then the option would be into IVF-XC. If there is no sperm found, then obviously the option could be donor sperm or going for surrogacy. So the third one is the normogonadotrophic, where the FSH levels are going to be completely normal. We already said this is more of obstructive reason. Again, genetic testing in here we have to keep in our mind is cystic fibrosis screening. About 98% of men with cystic fibrosis are infertile. These men have a cystic fibrosis gene mutation, which could affect the cilia in the vas deferens. About 98% of these men have associated congenital bilateral absence of vas deferens. Even though the cause is not known, but these mutations gene could cause problems in pancreas and lungs as well. So although the body would create a sperm, because of the absence of vas deferens or the problems with the motility in the vas deferens, this sperm does not reach into the ejaculate. So there could be a partial or complete obstruction of vas deferens. Again, with these cystic fibrosis men, partner screening is very important because these, as we know, are transmitted as autosomal recessive, so that we could consider the treatment of surgical sperm retrieval and IVF. For example, if a man has a cystic fibrosis carrier and the mother is a carrier as well, then there is a 25% chances of the baby could be affected by cystic fibrosis. So genetic counseling was very important on these couple before they undertake the IVF-XC, as well as considering pre-implantation genetic diagnosis. So the obstructive azoospermia, the cause could be past history of like vasectomy, or could be issues with cystic fibrosis and etc. Again, surgical sperm recovery is an option for these men, and if you could recover any sperm, IVF-XC should be considered. With an obstructive cause being a past history of vasectomy, if there are no coexisting female factors, then surgical treatment may be an option. However, the decision between surgical treatment of the vasectomy reversal or the surgical sperm recovery should be based on other factors like the age of the female involved, or if there are any other female factors involved, or any other coexistent male factors involved, and then the decision should be made. This is basically everything in one slide. So based on the FSH, if it's going to be low, then the problem is higher up. So you investigate to check if there is any issues in the pituitary, and these men couple would be benefit from FSH enlarge or HCG to improve the sperm numbers. Or if the FSH levels are high, then the problem could be genetic issue. So you do your karyotyping, and if any reason sperm could be retrieved, then they go for surgical sperm recovery, and if not, they go for donor sperm or adoption. or it could be an FSH or normal, it could be an obstructive cause. To keep cystic fibrosis in your mind, I have to do the genetic testing for the same. Again, we do imaging if there is an option, if the couple wants, the surgical correction is an option, and if not, they again go for surgical sperm recovery. The sperm is found, then they go for ICSI. If not found, then they go for donor sperm. So these are just a bit of introduction about various surgical sperm techniques used. So it's your PISA, TISA there, where the sperms are aspirated from the epidermis or testicles to extract the sperm under local anesthesia. Then there is a TC where the incision is made to take a sample from the testis, or the MESA where the epidermis are examined under microscope and fluid samples are taken to see if there is any sperm. And then again, there is a micro TC where this is again examined under operative microscope to see the best place to extract. So these three are done under the GA. So the surgical sperm retrieval techniques, the indications commonly used are mainly obstruction. There's an obstruction that's preventing sperm release due to an injury or infection, the congenital bilateral absence of vas, past history of vasectomy. And for non-obstructive azoospermia, it's used when the testicles are producing such low numbers which can't be retrieved. So they don't reach the vas. So that's where we go for surgical sperm retrieval. So definitely with the obstructive causes, the chance of successes for surgical sperm retrieval is certainly high than for non-obstructive causes. So the other main problem for male infertility is abnormal sperm parameters. Most of the causes for abnormal sperm parameters are idiopathic. However, there could be external factors which could play a major role, which we have already seen. So if abnormal sperm factors are seen, these patients could be advised lifestyle changes, go for a trial of antioxidants use, and then repeat semen analysis. And if we could recover good sperm, then obviously the options of IVF ICSI is there. And meanwhile, the partner could be tested for any other female factors as well as the male factors, including genetic testing, which includes cystic fibrosis gene. A couple of words about varicocele. So varicocele is a scrotal swelling which consists of dilated veins in the scrotum, and 90% of them occur in the left. It generally becomes apparent at puberty due to testicular growth and increased testicular blood flow. The diagnosis, however, clinical. Ultrasound with color Doppler may play a role. So 10 to 15% of males have varicocele in their lifetime. Clinically detected varicocele can be associated with abnormal gonadotrophin levels, impaired spermatogenesis, and histological changes in sperm. 20% of males diagnosed with varicocele will have fertility problems, and the incidence among primary infertility is up to 44%. Increased scrotal temperature, hypoxia, reflex of toxic metabolites leading to testicular damage may be the underlying mechanisms that can affect sperm quality. Again, the difference between whether varicocele should be repaired or try for surgical sperm retrieval is a controversial topic. There is some evidence to say that the surgical repair can show some clinical pregnancy rate improvement. However, the data used were very low in number. Even if the surgery is done, the time taken for the improvement of semen parameters is up to 3 to 6 months. It can take up to 3 to 6 months. So the decision should be individualized. So these are the medical treatments, and most of them are used to improve the sperm production and the quality. And the commonly used are gonadotrophins in here. A couple of slides about antioxidants, and I think the time is coming up and we're nearly done here. So there is some evidence to show that antioxidants does favor improvement in clinical pregnancy rate. This is a Cochrane analysis, which has done a study of various randomized controlled trial here. They've looked into vitamin E, zinc, and folic acid, which all favor antioxidant treatment. However, again, the sample size that were used were too small and there were too much bias there. So but what we tell men is antioxidants are generally good for health and there's no harmful effects, so they might use it and see whether that gives any improvement. So the one of the other reason that could be issues with azoospermia is could be an erectile dysfunction, which could be an issue, and these men are referred for psychosexual counseling, and sildenafil might play a role there. Again, surgical sperm retrieval is one of the options for there. Again, retrograde ejaculation could be an issue in these men. Again, IVF ICSI with electroejaculation is an option in these men. And that's coming to the end of it. And thank you very much for all your patience. Yeah.
Thank you, Kavita. That was an excellent presentation. I learned quite a lot because I'm not a infertility specialist. But now the floor is open to the trainees or participant to ask questions. Otherwise, the panelists can add something. Dr. Ali Alfera, do you want to add something to Kavita's presentation?
Thanks, Kavita. This was really an extensive presentations. A few things I just would like to say about the FSH, just to make it easy for our trainee. Imagine that the pituitary gland is a mirror of the gonads. So they are reflecting what's going inside the ovaries or the testicle. So when you do the FSH, and that means that the hypothalamus, pituitary, and ovarian or testicle axis you're testing. So if your FSH is normal, that means the hypothalamus and pituitary is working as well as the testicle. So you have to look at something behind the testicle, which is obstructed azoospermia. Now, if the testicle is not working like an old car, then you have to push more petrol and more gas to make the car jump. So when you see the FSH coming higher and higher and higher, that means the pituitary gland recognizes that the testicle is not working enough. So bumping the FSH higher and higher and higher. So look for the cause in the testicles or in the ovaries. And if you don't have enough petrols at all to make the testicle work, then your FSH is low. And when you have a low FSH, then look at the pituitary or hypothalamus part of it. So the testicle absolutely is not tested in this situation because the FSH is not enough to make the car jump. So look at the pituitary as a reflection for the testicle. Pituitary gland working very well, and there is no problem at all. Pituitary gland not working very well, the testicle will not work, but the reason will be either pituitary or hypothalamus. If the pituitary is pumping lots of FSH, then the primary factor in the testicle. The other things I would like to add is when the FSH, LH very low, check the testosterone. If the testosterone is normal, that's mean an external factors. So this is what you mentioned with your case, because these taking its steroids, and the steroids, the synthesis of the steroids goes through the testosterone. If your FSH, LH, and testosterone is very low, that does mean that it's not an external factor, it's an internal factor, either in the pituitary or the hypothalamus. That's for me now, but I'm happy to comment later on any questions or any suggestion from anywhere.
We got Dr. Shafi with us as well, one of the urology consultants from UK. Dr. Shafi, do you want to add anything, please?
No, I think the initial history taking is most important, and the physical features are from on the basis. I think the blood test plays a big role when you're having, because I think most of the people that come to see us are mainly saying, "There's, I just not having kids," and first you want to start with blood tests, and the blood test is a very good indicator, and also the sperm count to remember. I think with regards to varicose seals, I was trying to mention. I think that was. I think the talk was very, very good. Actually, I think you've covered everything. I'm quite impressed with the way you've presented your did your presentation. With regards to varicose seals, you have to remember if the varicose seals I just wanted to mention is that when we grade varicose seals, we grade them into 3 categories: grade 1, 2, and 3. One is that if it's grade 2 is basic. Grade 2 and 3 is more important for us because this is ultrasound delineated varicose seal, or by palpability that you can find the varicose seal. Then it is said that if you treat the varicose seals, there's a 30%. There's only a 30%. They say the research has shown that you can get up to 30 to 40% increase in the sperm count. I think the most important is assisted fertilization. Well, that's what we basically base our plans on, and we have to tell the patient that you have to continue trying because you never know when it's successful. So I think good counseling to the patient plays an important role in everything.
Thank you very much. Any questions? I think there is a question maybe. Is there any question from the trainees or participants? Anyone?
There's some mention about, can you please stop your slide share?
Yeah, we did. We did now.
It stopped it, yeah.
Sharmin, have you got any questions? You being in knowing something about infertility, have you got any questions?
I think from the young and the mid-level fertility specialists, they are struggling in Bangladesh when they are dealing with the male infertility cases. The first problem is the specific protocol is not established in our country is a problem. And the second thing is the scarcity of the specialized center, because male infertility sometimes need a multidisciplinary team approaches. Not all time the gynecologist or the infertility specialist will not solve all problems. Sometimes help of the andrologist is very important in here. It's have some problem in our country. I just want to know from Dr. Shafi Chaudhry that when a mid-level doctor got a case of azoospermia, then just a report, the patient come, the couple come, they didn't know anything in our middle class country. They don't have any idea regarding the male infertility also, because all time they are thinking all the infertility causes by the female factor. So they don't have any idea, any mental setup regarding their problem. So when we get a report with azoospermia, then what should our strategy? I want to know about the stepwise management protocol. What should be that?
Okay, first the strategy is because it's a social taboo in many cases. First of all, you need to have a one-to-one with the gentleman without the wife. And that's what we face also in England. Although we're in England, you have to remember we have a huge Bangladeshi population as well. And the mentality is not as any different from what you see in Bangladesh. Okay, the only difference is that because we're in England, we've got maybe more technology comparatively, but not necessarily that we're giving, it's going to be different in the consultation. The most important thing that you have to say to the gentleman is first, you need to make him understand what the problem is. All right. But you can only tell him about the problem by starting. Obviously, you're doing your history and examination, everything. Let's say you are seeing this gentleman with all his tests available. When you're saying that there is no sperm, then obviously you have to spit it out and say that, yes, you've got no sperm, but I need to find out why you don't have any sperm. And as our presenter today quite beautifully has presented, that you have to think whether this is a true azoospermia opposed to an obstructive azoospermia. Okay? If it is obstructive azoospermia, then obviously you have to explain to him what can and cannot be done. The problem that I don't know about Bangladesh is that I don't know what kind of, do they have sperm retrieval facilities in Bangladesh at the moment? Can you tell me? Sorry, I'm not very
Yes.
aware.
Yes, there is a facility.
What kind
There are
of-
many.
I think
Yes.
to start with, this conversation should have started as an MDT. It should be in presence of an andrologist and yourself in the same room, speaking to this patient and saying, this is the problem, okay? Once you've identified, as I said to you, the first thing that you need to do is identify this azoospermia. Is it obstructive or is this pure? I'm just trying to make it easy for you, the easy understanding wise. Obviously, there's a lot of, stratifications on that, but I'm just gonna make it very simple. Is it obstructive or is this pure? If it's obstructive, then you have to tell him it's obstructive. Then we need to find out why is it obstructed. For example, if he's got an issue with his vas, then that needs to be sorted. Let's say he had a vasectomy, and this is going to be, he's still looking for a second child, then he has to have a vasovasostomy, meaning he has to have a vasectomy reversal. If he has an ejaculatory duct obstruction, then obviously urologist will have to go and open up his ejaculatory duct by doing a resection. That can be done. Or if there's any surgical methods that can be done. If that cannot be corrected because he's, let's say, for example, he's had some sort of tuberculosis or some kind of infection because the vas is completely obstructed, the only way is by sperm retrieval, isn't it? There's no other way you can sort this problem out. On the other hand, if the patient is a pure azoospermic, then you have to find out what kind of azoospermic is he. Is there any way we can offer him clomiphene and improve his sperm counts? Or does he have a varicocele that can be improved? That's fine, okay? But it's mainly the understanding. Unfortunately, education plays a big role in making them understand. And I do understand there are a lot of men that come who are not very, very educated and their understanding is very poor. So approaching them is not always easy, and that can result in an emotional discussion, isn't it? So very, very challenging, I would say. But it would be nice to have it done, I would say, in presence of an andrologist talking it.
Thank you. Thank you, Dr. Shafi. Now we got few questions. Dr. Bushra Zahan has asked, what is the dose of HCG in azoospermia? Please, any of you can answer that, Dr. Ali or Kavita or Sharmin, if you know.
I usually use 250. Well, depend on the reason for azoospermia again. I guess this situation, the reason for azoospermia, either Kalaman syndrome or a pituitary dysfunction, hypogonadotrophic. So I will use 250 twice weekly. FSH, Minipure will be also okay. 250 twice weekly till the sperm, and then I will do the sperm test every 3 months. I would not expect most of them to get a normal sperm count, but there will be enough sperm to store for IVF and egg. You'll probably get around between 5 million to 10 millions. That's my own experience.
Okay, next question from Dr. Mahmoud Hassan Amin, saying is there any evidence of amount or frequency of smoking associated with the infertility?
I think there is no much evidence on the same. Even though it affects sperm parameters, as such, they don't know how much it is affecting, but we generally do advise men to stop smoking, and we do see improvement in sperm parameters. I don't know, Dr. Ali, you have anything to add up on that?
Unfortunately, we currently blame smoke for everything, and it is known to be a cause for cancer in multi-organs, really.
That was going to be my same answer. You blame smoking for everything. Well, we already know, just ask them to stop smoking.
Yeah, and want them to start their life healthy, to be honest. And I agree, with the heavy smokers, I've seen improvement in the motility, but I did not see an improvement really in the number of the sperm itself. But it's an opportunity, window of opportunity as a pre-counseling to start their life healthier and increase their life expectancy.
That's what we do as well.
Yeah.
We gently tell them off to stop.
Yeah, so we're not encourage anyone to smoke, but we also don't want them to expect that as soon as they stop smoking, there will be a miracle there. Okay, so same thing. Dr. Mahmoud Hassan Amin has got another question. How do we preserve fertility for young person before giving chemotherapy, like for germ cell tumor or other malignancy?
You have to store them. You have to store as much as you can. And you can store them up to the age of 55 or longer even. this is very well known a process before you do any surgery for testicle or any chemotherapy to store the sperm to be used in the future for XC.
Thank you. Then I got a question from Dr. Mahbubul Alam. All the hormonal values, so he gave a scenario, all the hormonal values are within normal limit with normal testicular ultrasound, and FNAC shows late spermocytic arrest. What may be the cause and what may be the treatment options? So I repeat, all the hormone values are within normal limit, normal testicular ultrasound, FNAC shows late spermatocytic arrest. So what may be the cause and what may be the treatment options? Anyone, Dr. Shafi?
It's maturation as arrest, isn't it? I mean, all the parameters, it's basically arrest completely. So I don't think there's much that you can be doing from that one, this guy.
We just say sorry.
Yeah. Other than so what was the numbers for this from semen analysis?
Dr. Alam, are you still there? Can you tell us what was the numbers?
Yeah.
Can you?
Yeah, we need the whole semen analysis as well. That's why I know you're giving the picture, but we need to have a semen analysis picture as well. Is it azoospermic completely?
I don't know whether he's still in the audience, but there is another question. Role of adjuvant in poor sperm motility. I think he meant role of adjuvant therapy in poor sperm motility. I'm not sure whether he wanted to know, or he or she, I think it's a Janat who's just mean, whether it's, is it antioxidant or adjuvant?
Yes, actually in Bangladesh, when there is a low sperm motility or count, many of the fertility specialists are using some free radical adjuvant type, yes, antioxidant, and sometimes some UBQ type of medicine. So she wants to know, is there any role of the adjuvant which will help? Sometimes commonly in our country, vitamin E and C combination is using for this type of patient. So is there any role of vitamin E or vitamin D analysis to show, because sperm motility have a strong relationship with vitamin D. So in case of sperm abnormality, do we need to do a routine investigation of vitamin D for all the male? What's your suggestion?
Have you got any idea or anyone?
Well, yeah, well, I've had a very poor association, but the question is that in Bangladesh, I don't think the vitamin D will be low, it will be rather high. Vitamin D is low in England. That's the biggest problem we face. We've got osteoporosis and we've got arthritis. So,
Exactly.
But it's a bad luck for us. In 10 women, there are more than 5 women who have vitamin D deficiency in our country. We have lots of sunlight, but the scenario is a very depressing for us. And also same with the male patients also. So it's a very depressing situation.
That's why I was rather surprised when you asked the question. I was saying.
So maybe, what is the reason? Because they are too busy working inside and they're not going outside. What is the reason?
It may be all are confined. All are confined in the room and in the office. So they have a less time to exposure in the sunlight maybe. Because when we do the analysis, we just get this result from many of the infertility centers.
Too much air conditioning.
Yeah, I think they needs to be told on Fridays, they just have to get out of the house.
Yeah.
And the air pollution is one of the important cause, because due to the polluted air, many people are avoid to exposure in outside. And one question from one of the student of us, that if we get any abnormal semen analysis, so in UK, what are the protocol you are following to do the second semen analysis report? Because in Bangladesh, to seeing one report, we never recommend that you have a problem in the semen. They want to do another. So what is the recommendation to do the another report after 1 month or 2 months or in between? Do the patient need any treatment?
No, not at all. What we do is when we have the first analysis, we then ask the patient not to be abstinent from sex for 2 weeks. I know it's tough sometimes for me, young guys, but we tell them that's what you want to do. definitely 4 days abstinence from sex, okay, and have a second sample. This is standard practice. We never go by the first sample. If necessary, we even send them to a different center to have the sperm checked as well. Yeah, so we don't jump to conclusions straight away.
Ali, do you want to add anything?
In my own practice, we take a normal value of sperm, and it's fact. I don't repeat the normal value of sperms. If it's abnormal, depending on the severity of abnormalities. If it's severe oligospermia or severe abnormal parameters, then I will repeat it as soon as possible to confirm, because these ones, they need an IVF XC as soon as possible. It's XC basically. If it's a mild abnormalities, then I would probably advise them for antioxidant, multivitamins, stop smoking, reduce weight, and then repeat it again in 3 months' time to see. There's a lot of time there is significant improvement in the mild abnormal ones and will become normality. But this is my own practice. As long as you have a normal semen analysis, I would repeat it at least once a year if their journey continue. Again, we have rules for IVF, the access for IVF XC here. It's been funded by the government, and the access is much easier. So if they already been 3 years trying to conceive, and even with the normal semen analysis, no other parameter, they will be qualified for IVF. So they have a much easier pathway to be qualified. But I don't really repeat a normal value, and then I'll repeat it after 3 months if it's severe, because the severe parameter is extremely unlikely to improve in my own experience. That's why I repeat it as soon as possible. Thank you.
That's exactly we follow here as well. If it's abnormal, we advise them to stop smoking and do lifestyle changes and take antioxidants and repeat it. But if it's normal, then we don't tend to repeat it.
But what's your personal experience? Antioxidant, does it improve the sperm quality, the count, or motility? Dr. Kavita?
We have seen, but obviously we are a small unit. We don't have too many cases in here. But as far as we have seen, yes, we routinely do advise on antioxidants, and we do see improvement in here. We do see improvement in the sperm parameters, but whether the successful of clinical pregnancy is not studied because it's a small unit here.
Ali, do you want to add something, please?
It's exactly the same. I think it's dependent on the severity of the abnormalities. Again, if you have a severe abnormal sperm, somebody sperm count 2-3 millions, or motility is 10%, or abnormal form 1%, this is extremely unlikely that antioxidant, especially in this country, the people, to be honest, is extremely healthy and practice exercise, multi-food and fruit and vegetables. They are aware of vitamin supplement. So I wouldn't expect any improvement, or if the improvement is not to the improvement I want to see. But if you have a mild abnormality, somebody with the motility 35%, sperm count 12-13%, then I think there is a role for it for 3 months, at least 72 days, because that spermatogenesis take from seeds to fully grown sperm takes 72 days. But I wouldn't expect to see massive improvement in the severe.
I think there is another question from Lipi. Is there any role of endocrine evaluation in case of only asthenospermia? Endocrine evaluation in case of only asthenospermia?
Not my practice. Again, the endocrine evaluation, FSH, LH, prolactin, and other hormones, they are valuable, and they differentiate between obstructed and non-obstructed azoospermia. This is my own practice, really.
Thank you, everyone. We can give another 4 minutes, then I think we're going to conclude it. I basically learned quite a lot, and I'm sure our trainees has been benefited as well. But I'll be very happy to receive the questions or anything you want in my email, and I can communicate with my colleagues. I think Dr. Shafi, Ali, Kavita, they'll be very happy to give me the input, then I can actually reply back to you all. So any further questions? Otherwise, we'll thank you, everyone, and we conclude the session. Any questions? So I think I thoroughly enjoyed. I'm really, really grateful to Ali, who's actually going to join us in our unit in Nobles Hospital in end of April. He's currently working in James Paget. So we're looking forward to have Ali with us working as infertility specialist. I really thank Kavita for taking time to make this wonderful presentation, which was very thorough and very informative. Thank you very much, Kavita. Shafi, you also took time in the weekend to come and help us and help our trainees. Thank you very much. Thank you all. Have a good
You're welcome.
weekend.
Right.
Thank you.
Thank you. Bye-bye. Bye.
Bye. Thank you, Roshan Madam. Thank you very much for your presence. Thank you, Kavita. And thank you, Countries Thoma, for for all the supports you have been providing us for this meeting. Thank you. Thank you, everyone. Have a good weekend.
Thank you. I enjoyed it a lot.